Hello everyone, and welcome back to our Clinical Mastery series. My name is Dr. Beno Sevwe, DNP-PMHNP. Today, we are embarking on an intensive deep dive session specifically designed for PMHNP students and clinicians who want to master the complex nuances of psychopharmacology for their boards and daily practice. Our focus today is Desvenlafaxine, widely known by the brand name Pristiq. We aren't just looking at the surface, we're covering mechanism of action, precise dosing, safety warnings, and those high-yield board exam pearls you'll need for certification. Please remember this is for professional education and does not replace medical advice. Let's start with the pharmacology. Desvenlafaxine is an SNRI, or serotonin norepinephrine reuptake inhibitor. It works by blocking the reuptake of both serotonin and norepinephrine. This increases their concentration in the synaptic cleft, which is vital for patients struggling with the decreased positive affect cluster of depression, fatigue, loss of interest, and cognitive fog. For your boards, pay close attention. Desvenlafaxine is the major active metabolite of venlafaxine. This is clinically significant because venlafaxine requires the CYP2D6 enzyme for conversion. Desvenlafaxine bypasses this, making it a more predictable option for poor metabolizers or patients taking other medications that inhibit the 2D6 pathway. I love this analogy. If venlafaxine is the parent, Pristiq is like the adult child who moved out, got his own apartment and said, "I can do this myself." It's ready to work immediately without needing that extra hepatic processing step. It's built for efficiency and simplified pharmacokinetics. The primary FDA indication is major depressive disorder. When you're in the clinic, use the SIGECAPS mnemonic to screen. Desvenlafaxine is particularly helpful when patients need a boost in energy and focus, thanks to that norepinephrine component. Remember, for a diagnosis of MDD, you need 5 out of 9 symptoms for at least 2 weeks, and one must be depressed mood or anhedonia. Diagnostic distinction is crucial. Always differentiate MDD from bipolar depression and dysthymia, now called persistent depressive disorder. An SNRI like desvenlafaxine is a first-line choice for MDD, but it could be disastrous for bipolar 1 without a mood stabilizer. Precision in diagnosis always precedes precision in prescribing. Beyond depression, you'll see it used off-label for generalized anxiety and menopausal vasomotor symptoms. For patients in the perimenopausal transition who are also experiencing depressive symptoms, desvenlafaxine can be a very elegant dual-purpose selection, addressing both mood and the physical discomfort of hot flashes. Diving into pharmacodynamics. By inhibiting reuptake, we are facilitating longer-lasting communication between neurons. This sustained signaling doesn't just improve mood, it helps regulate emotional responses and can even improve physical symptoms of depression like aches and pains. It's about restoring neurochemical balance to the prefrontal cortex and limbic system. We must manage expectations. Week 1 is often just about tolerating the medication. By week 4, the patient should feel a shift in energy. Full therapeutic effects take 8 to 12 weeks. As I always say, if depression could be fixed overnight, we'd be prescribing sleep and soup. This is a journey of neuroplasticity, not a sprint. High-yield pearl. The standard dose is 50 milligrams once daily. Clinical trials show that doses above 50 milligrams don't consistently provide more relief, but they do significantly increase the side effect profile. Start at 50 and be very intentional before moving higher. In psychopharmacology, more is not always better. Always check your patient's labs. Desvenlafaxine is primarily excreted by the kidneys. If their creatinine clearance is below 30, you must adjust. The recommendation is 50 milligrams every other day, or 25 milligrams daily. Ignoring renal status is a major clinical red flag, and a frequent board exam question. Precision dosing is safety. Pristiq uses a sophisticated extended release matrix. Patients must swallow the tablet whole. If they crush or split it, they get the entire dose at once, a phenomenon called dose dumping. This leads to toxic peaks and then a rapid drop-off, making the medication both dangerous and ineffective. Patient education here is mandatory. Never stop an SNRI cold turkey. Discontinuation syndrome is real and can be terrifying. Dizziness, intense nausea, and those infamous brain zaps. When it's time to stop, use a slow, supervised taper to keep the brain's neurochemistry in balance. We want to glide them down, not let them drop. Let's discuss drug interactions. Never combine with MAOIs. You need a 14-day washout. Use caution with NSAIDs or anticoagulants due to increased bleeding risk. And be wary of serotonin stacking with triptans or St. John's wort. Always do a thorough medication reconciliation before your first script. Let's talk about the big 3 side effects: nausea, dry mouth, and sweating. I tell my patients to take it with a small snack to minimize GI upset. Most of these symptoms are front-loaded and will significantly improve after the first 2 weeks of consistent use. Reassurance is a part of the treatment. You must monitor vitals. SNR can cause a dose-related increase in blood pressure and heart rate. Baseline vitals are mandatory. If a patient's blood pressure is consistently elevated after starting, you need to either treat the hypertension or switch medications. Safety is our first priority. Safety first. The black box. Warning for increased suicidal ideation in children and young adults applies here. Monitor your younger patients weekly during the first month. Also, always screen for bipolar. Giving an SNRI to someone in a depressive phase of bipolar can trigger a dangerous manic episode or rapid cycling. Be on the lookout for serotonin syndrome. It's rare but life-threatening. The triad includes mental status changes like agitation, autonomic instability like fever or tachycardia, and neuromuscular hyperactivity like tremors or rigidity. If you see these, stop the med and refer to the ER immediately. It's a medical emergency. What do we tell families? This medication isn't a happy pill and it doesn't change personality. It simply lowers the volume of the depression symptoms. This allows the patient to actually use the coping skills and therapy we're providing. Think of it as the floor that supports their recovery, not the ceiling of their potential. Case study 1. A 62-year-old male with uncontrolled hypertension and stage 3 chronic kidney disease. Would you start Pristiq? His CKD means we'd need a lower dose, but his uncontrolled blood pressure is a major contraindication. You must stabilize the BP first. This is where your clinical integration really shines. Case study 2. A 22-year-old female presents with severe depression. Her mother mentions she had a period of unusually high energy and impulsive spending last year. Would you give her Pristiq? No, that's a red flag for bipolar 2. You'd need a mood stabilizer first. Missing that high energy history is a classic board exam trap. Final board recap. 1. It's an SNRI affecting serotonin and norepinephrine. 2. It's the active metabolite of venlafaxine. No CYP2D6 needed. 3. 50 milligrams is the therapeutic sweet spot, with no added benefit at higher doses. 4. You must monitor blood pressure at every single visit. No exceptions. 5. Swallow it whole. No breaking the matrix. 6. Taper slowly to avoid discontinuation syndrome. 7. Always screen for bipolar history before starting any antidepressant. 8. Adjust for renal impairment based on CRCL. Memorize these 8 points and you are ready for your certification exams and your clinic. Desvenlafaxine is a versatile and effective tool in our psychiatric toolkit. When we combine it with clinical expertise, deep patient education, and close follow-up, we are giving our patients the best possible chance to reclaim their lives from the weight of depression. Balanced, holistic care is our ultimate goal. Thank you for joining me for this intensive deep dive. I am committed to your success as future PMHNPs. For more mentorship, case studies, and resources, text 83299-16516 or visit rotationmatchnetwork.com today. Let's grow, learn, and elevate our profession together. And always remember, anxiety and depression may be loud and overwhelming, but with the right treatment plan, skills, and professional support, they do not have to be in charge of your patient's life. You have the knowledge and the power to help them heal. Keep pushing forward. I'll see you in our next clinical mastery session. Keep studying, keep caring, and as always, educate, monitor, support, and follow up. Take care of yourselves out there. I'm Dr. Ben, and I'll see you next time.